All right, cool. So now we've got Masum presenting, and he's talking about health interventions for refugees. Take it away.
Hello, everybody. Welcome to my presentation. I would like to talk about my research paper on health promotion interventions for refugees in high-income countries, a systematic review and narrative synthesis. This is basically part of my systematic review. Some parts of it I presented in the last month in the University of Queensland as part of OSRNT 2024 Oceania Conference. So I'm presenting here another part of my paper, what I developed as part of literature review of my PhD project. First of all, I would like to acknowledge the traditional owners. Traditional owners of the land where we work and live. We are in Gambiagir country and we acknowledge the traditional owners of this land, the Gambiagir nation, and pay respects to Gambiagir elders past and present. This is the overview of today's presentation. First of all, I would like to talk about health promotion. Health promotion is a comprehensive approach to promoting health by engaging multiple stakeholders and utilizing multi-sectoral strategies, a response to developments, emphasizing the direct or indirect impacts on health, such as inequalities, lifestyle, and cultural beliefs. Research suggests the community consulted approach, is the best practice for health literacy, health promotion, and service delivery for migrant populations. For optimal healthcare at the clinics, several strategies may involve bilingual or community health workers, cultural competence trainers for staff, and culturally appropriate health promotion materials. Who is a refugee? A refugee is someone who has been forced to flee their country because of persecution, war, or violence. They have a well-established fear of persecution due to race, religion, nationality, political opinion, or membership in a particular social group. Refugees most likely cannot return home and they need international protection. They are an underserved and underprivileged community having significant health needs. They also experience several health inequities. A review of 64 studies of culturally and linguistically diverse population, whom we call cult populations, showed limited health literacy, multimorbidity, communication problems, restricted cultural competence and service providers were the main barriers for these communities to access healthcare. Well, approximately over 36 million refugees were displaced at mid-2023 across the world. Over half of all refugees just originated from these three dominant countries. Around 6.5 million refugees come from the Syrian Arab Republic, while over 6 million refugees come from Afghanistan and Ukraine, respectively each. The Islamic Republic of Iran and Turkey is hosted over 3 million refugees, the largest refugee communities worldwide in mid-2023. Germany was third with 2.5 million refugees, followed by Colombia and who was just slightly less than 2.5 million refugees. The top 15 refugee host countries now accept 75% of all refugees, 10% fewer refugees than the 1980s. That means refugees now come from a decreasing number of countries of origin and move to an increasing variety of destinations over the time. Well, health promotion interventions for refugees in high-income countries are not currently sufficient, suggesting a scarcity of, showing a scarcity of healthcare for refugees with non-communicable diseases. Exposure to smoking and alcohol use disorder further increases the risk of physical and mental disorder, leading to multimorbidity and mortality for refugees. For instance, fathers of refugees reported poor physical and mental health rather than Australian-born fathers. This is for Australian study. In the US, older refugees had more risk factors like smoking, being overweight, and less physical activity than younger adults. Well, we found a limited research on the effectiveness of health promotion interventions for smoking, alcohol use disorder, nutrition disorder, physical inactivity. Previous systematic reviews focused on a single SNAP behavior. This is the first systematic review and narrative synthesis paper where we accommodated all SNAP behaviors related to NCDs and health promotion interventions. This is the uniqueness of this paper. We covered all the SNAP behaviors. Well, where is the problem? What are the problems exactly? We look at this paper. Refugees normally are screened for communicable diseases when they arrive in their host country. Non-communicable diseases and risky behaviors may be overlooked or developed after arrival. Implications these factors pose for health promotion are not well understood and not well documented. Those are the main factors what we considered to develop this paper. In this connection, this systematic review examines the health promotion needs of refugees in high-income countries, specifically addressing smoking, nutrition, alcohol use disorder, and physical inactivity or activity behaviors, and exploring relevant health promotion interventions. This is essentially systematic review and narrative synthesis paper, which applied the PRISMA guidelines for electronic bibliographic databases such as Medlines, CINAHL, PsycInfo, and Web of Science were searched for this study. Original research papers focusing on adult refugees, which were in English only, were included, published between 2000 and 2023. Well, this study protocol was registered with Prospero, which included studies from high-income countries presenting data on refugees, SNAP behaviors, and health promotion. We excluded studies on child refugees and asylum seekers. If we included them, it came up with a large number of papers, which were difficult to review. Due to high heterogeneity, a narrative synthesis approach was applied to synthesize the findings instead of following any meta-analysis. Well, we had 12 papers for this study. We got, 20 papers. We got 12 papers from the US, 2 papers from South Korea, 1 paper from Canada, New Zealand, Switzerland, and Sweden as well. So you can see the picture of Australia. We have just only a couple of papers regarding this issue, though Australia is a very multicultural country where we have heaps of refugees, asylum seekers, and many more, especially culturally and linguistically diverse population. Well, in terms of the categories of studies, we got 15 quantitative studies, mostly from US, and 4 qualitative and 1 mixed method studies. The entire population size what we included for our studies came up with over 45,000. Well, I will talk about the findings of this systematic review. First of all, men had a higher prevalence of smoking and alcohol use disorder than women, suggesting gender disproportionate non-communicable disease burdens and related other health burdens. Women had a higher prevalence of depressive symptoms, post-traumatic stress disorders, obesity, and related non-communicable diseases risk rather than men. Unhealthy diets and physical inactivity may contribute to developing overweight, obesity, micronutrient deficiency, parasites, anemia, and so on. What we found as a factors, length of stay, as many days culturally and linguistically diverse populations or even refugees tend to spend time in the host countries. Even nativity and post-traumatic stress disorder accelerated SNAP behaviors and are likely to contribute to developing heart disease, lung cancer, diabetes, hypertension, and overweight, obesity. Well, culture and language sensitive health materials, culture and language sensitive educational campaign, cooking workshops, alcohol counseling, cessation aids, and free sports and physical activity sessions were health promotion interventions from the included research papers. Other interventions included peer support, community engagement, additional training for mental health care providers, residential detoxification programs, and religious values. Well, health promotion interventions varied across different SNAP behaviors, language and culture appropriate services for all cases of health promotion interventions appear to be the robust concerns for the refugee communities. Engagement of media, peer support, and community empowerment were often overlooked. Most studies described the health risk behavior and rarely found solutions by suggesting health promotion interventions. A few studies explained trialing interventions. Future tobacco policies should follow the Ottawa Charter protocols and multi-sectoral collaboration. At the same time, also other health policies were considered. What we didn't find in this study that were actually co-designing method, which I'm approaching in my PhD thesis, for making any blueprint for this disadvantaged community to promote their health. We didn't find any co-design paper. Even we got few papers on longitudinal studies. So both this type of study designs have been encouraged to go for further studies for picking up health promotion issues, health promotion strategies, their needs to cover up or to promote health for these disadvantaged communities. Thanks.
Thank you. That was so interesting. And I'll just take the first question myself. Can you tell us the difference between a refugee and an asylum seeker?
Oh, well, refugee people have some already legal commitments from the government. The government is supposed to do something for the refugees. Like at the moment, Australian government is giving some subsidies for their living here. But asylum seekers are those people who haven't got the status of refugee, but trying to get the status of refugee to get some sort of incentives from the government or the state, something. Yeah, because they are just still processing their papers. And sometimes actually look, when some people just trying to touch the ground or even come into the, through the river by boat or something, they try to seek help. But that depends on the government actually how government will behave with them, whether they will be really accepted as part of refugees in Australia or not. That's why government or state people, they need to consider their all documents, whether is it actually they are displaced due to conflict or other stuff, which has international, commitment to the UNHCR, United Nations for Refugee. So if they fill out all those conditions actually for any state, not only Australia, so then they try to think of considering them as part of refugee for this country or something. Yep.
Cool, thank you.
Yeah.
All right, questions?
Language and culture are the main barriers.
Sorry?
Language and culture.
Yep.
How do you come across these situations when you analyze a data? Your data points are very less.
Sorry?
Data samples are less. How did you find out the conclusions?
My sample size is less, you were saying?
Yeah.
How?
You have considered only 20 points, I think.
I considered 20 papers.
20 papers.
Yeah, so isn't this is not less paper, you know?
No, there are a lot of papers, hundreds of papers on the internet.
Yes, there are hundreds of papers, but actually we went through some inclusion and exclusion criteria. We have some sort of criteria which we strictly follow.
Even if you include or exclude, even I'm doing scoping review and a systematic review also.
Oh yeah, okay, fantastic.
Yes.
So you know where, yeah.
So we come across a lot of samples.
Yeah, I know, but what you were saying, I understood. But when we got huge papers, it was difficult to analyze. So that's why we reduced a number of papers, saying we just, we actually avoided some papers from asylum seekers, even those refugees who are under 18. So that's it. But we came with 20 papers. That's it.
And how do you come across the human situations, the language and culture situations to overcome in your analysis and analytics, data analytics, social analytics?
Could you repeat, please?
In your social analytics, social informatics, how do you take into account the situations of language and culture,
okay,
of demography and geography?
Well, I understood your point. Actually, I used, this is called Excel sheet for each article. So we have different domains for data analysis. So we put on is like health promotion. So underneath, we got different factors like this. These are the barriers for accessing, for health promotion strategies here in high income countries. So in that connection, we got some, for 20 papers in a particular column, we got is points. So from there, actually, we counted and considered, actually, these are the, top-notch barriers for them.
Hi, thank you very much. It's fascinating information. I am curious about, this might be early on, but from your early analysis, what do you think is the most important thing a government can do to support refugees' health?
Government?
A government like Australia with its refugees, what's the most important thing that the government can do?
Well, for culturally and linguistically diverse population, even for refugees, even for asylum seekers, like this sort of disadvantaged communities, Australian government actually has a does not have very big national program regarding this health issue. So that's the one issue. Another thing, Australia has like 3 layers of health system here. Budget for the health. So normally like national, federal, and also local level. So what our studies say, they need to collaboration and cooperation based on the real scenario in the field. The thing is that there are some sort of gaps in between health professionals or even healthcare people and the clients who are likely to receive healthcare. So the major issue is here, it might be related with like interpretation service or even language service or even other stuff like this. So what I found whenever I visited nearby hospitals I'm working at the field level, so I found actually sometimes this is difficult for the patients to get the interpreter in real-time situation. So, in Australia itself has some sort of issues related with if someone, Australian citizens even go to for emergency care or even other like surgical operation or something, it takes a lot of time actually. So for refugee communities or even this sort of people, it takes also longer rather than the very normal period. So these are the issues actually where government still need to focus to work on it.
Great.
Yes.
Thank you so much. I appreciate that.
So there are plenty of issues actually. I'm just explaining, just summing up just shortly. Yeah. Yeah.
Okay, so we've
question?
probably got time for one more quick question. Barney, do you want to start coming down? In the meantime, do we have any other questions? Just while we get ready for the, yeah.
I just have a kind of not so important questions. Like in one slide you mentioned, like you compared the health with an Australian-born father.
Yes.
So how,
I didn't compare, the study compared, I just talked about it.
Okay, so
Yeah.
like how is that? Like, is it good or bad? That's my question. I don't really know about that.
Sorry?
Like, so how healthy is it? Like, or how bad health is? Like, I didn't understand like how you compared or the study
Oh,
compared.
okay, I'm saying this study was conducted by Australian scientists, not me. So I just added it as part of literature. So that study said that rather than Australian-born fathers, those are fathers who are not born here, just overseas born, they have less, health facilities or even, their health outcomes are not good as Australian born. That was.
Okay.
Yeah.
Okay. That makes sense.
That's not my study exactly. That is just literature. I just, yeah.
Thank you very much.
Okay, I'm done. Okay, thank you.
Yeah.